When I was a neurosurgical resident, I had a special interest in brain aneurysms. Brain aneurysms are like ticking time bombs in your head. And what's scary about that is that 3% of the population has them. And although most of them don't rupture, when they do, it's almost always a death sentence. And those who survive often have a very poor quality of life, and well, gosh, you wonder if it's worth living. The scariest thing about this stuff is the typical story that it presents with. It's usually somebody in their 30s or 40s, somebody you might know, totally healthy, suddenly develops the worst headache of their life, and boom, within minutes goes from a vibrant living human being to either dead or in a coma. Now, the good news is that we now have a screening option that can find aneurysms, early cancer, and a whole host of other problems that can be treated effectively if detected early. The technology is whole body MRI that has been optimized for full body surveillance by a company called Preventive. Not only is this technique able to pick up big scary things like aneurysms and tumors, but it can also help you learn about ways to optimize your health based on the findings. Now, my guest on Sapio with Buck Joffrey this week is Dr. Sean London. Sean is board-certified diagnostic radiologist and the lead radiologist at Preventive with an extensive expertise in the practice of whole-body MRI imaging. Sean and I discussed this new twist on an old technology that's adding a huge tool to our Medicine 3.0 arsenal and lets us, as patients, play offense in the world of preventative medicine. Make sure to tune in, and if you like what I'm doing, like, share, and subscribe.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
Hey, welcome to the show, Sean.
All right, thank you for having me, Buck.
Of course, and this is super exciting for me because I have to tell you, I got introduced to Preventive. Is that how you pronounce it, by the way?
Yeah, Preventive.
Preventive, and I got introduced to it by actually one of my investors. As it's a long story, but I have another career outside of my podcast here, and he is another physician. He's a radiologist. Actually works for Preventive, and he told me, "Hey, why don't you look into this this MRI thing that I'm doing?" And I was like, at first, my response was, "Okay, yeah, that sounds interesting, but not really," because I'm like whole body MRI. Okay, whatever. But this ended up being a really interesting topic, and I'm excited to talk about it with you. But before we do that, let's talk a little bit about you. So, Sean London, you are a radiologist. For people who don't really even know what a radiologist is, what is a radiologist, and what's your background?
Yeah, so radiologists are physicians who interpret imaging studies, and it can be from a wide variety of studies, different modalities. Ultrasound, X-rays, CT scans, MRI scans, and nuclear medicine as well. So it encompasses a pretty broad area of imaging itself. My background is, I'm a board certified radiologist. I went into subspecialty training for a year at the University of Washington doing body imaging. And then after that, I entered practice and a private practice and was doing, typical diagnostic radiology. It was good, but it wasn't quite fulfilling. And then I came across Preventive, and I saw their imaging, I saw the concept, and I loved the idea and the direction they wanted to go. And so I jumped right in.
Yeah, and so one of and that kind of brings me to the next point, which is that I've talked about this concept on this show several times now of what I call Medicine 3.0. Medicine 1.0 is like, leeches, things like that. Medicine 2.0 is, all of this stuff that we had in the last 50 years, just diagnostics, things like that. 3.0 is different because now it's not just about playing defense, right? All we've done for years and years, and you look like you're a little bit younger than me, but things didn't change that much. Medical school, when you go in there, even as a radiologist, describe the typical way that an image comes to you and what you're doing when you look at that image. And what I mean by that is, what is your mind frame? What perspective are you looking at it from? Because that's very different from what we're talking about here.
Yeah, generally it's like diagnostic exams, right? People come in with a complaint or symptoms. They get a particular study to try and answer that question. So when I'm looking at that exam, I'm looking to answer that clinical question, and I'm not necessarily ignoring all the surrounding stuff, but I'm not focused on it as I am with my current type of imaging, this whole body screening imaging.
Yeah. So effectively, you're just saying something's wrong or something is not wrong with the thing that you asked me about.
Exactly.
Right?
Do you
Ultimately,
have appendicitis or you don't?
Yeah. And so, and the reason I bring that up again is it goes back to playing offense and playing defense, right? So Medicine 2.0 was great. We have diagnostics, but at the end of the day, it's like you go in when you have a problem to find out, hey, my stomach hurts. Is there something wrong with me? Medicine 3.0 is where we've talked about it in the context of this show, is taking technology, diagnostics into your own hand and attacking, any potential issue before it becomes a problem. And that's a totally different ball game, right? So when it comes to let's do this. There is a role right now in radiology for prevention, right? I mean, that's as close as we get to 3.0 in current medicine. These are screening measures, which, they're recommendations. And maybe you can talk a little bit about what the current standard of care when it comes to screening and radiological techniques is.
Yeah, I mean, off the top of my head, I can think of very few radiologic exams that are actually used in the screening setting. So let's start with one that we all know, mammograms, right? Mammography. And then there's even like screening breast ultrasound. The other ones I can think of are CT colonography, that can be used for like average risk individuals. What else? Coronary artery screening. So there really aren't a lot of different types of imaging available in the screening setting. Oh, and obviously low dose CT chest. So,
right. And so that's specifically for like smokers, for example,
yeah,
right?
Definitely
right.
people at higher risk.
Yeah. Yeah. So I guess one of the questions that we need to address is if we're looking at it from that 3.0 approach, and if we know what the statistics are on various things, like how many people get cancer, how many people have aneurysms, why is that not enough, what we're doing right now?
Yeah, I mean, if we're only looking at those particular screening studies, we're ignoring a lot of people. They're not necessarily at high risk of developing cancer, but they are at risk of developing cancer or other disease processes that could affect their life. And this kind of opens it up to a more general population who want to know answers, who want to change lifestyle based on certain findings that we may come across. So we can always do more and improve our lives and our longevity.
I think when I think about like why this is, why is that not enough? I look at just flat out statistics. Like what % of the population has a cerebral aneurysm, like a brain aneurysm?
Yeah, I mean, it's probably close to like 1 in 50, right? Like,
it's definitely at least 1%, 1 in 100. And in a former life, I was a neurosurgical resident, and the survival on that, with a ruptured aneurysm is, it's maybe 10, 15%. And then I wish I was dead if I survived was about 90% on top of that, right?
Yeah.
Whereas we have very, very, in neurosurgery has evolved a long way with the help of radiology, where if there's a brain aneurysm now, it's actually something that you can potentially just go in through the thigh and go in there and fix. And the next thing you know, you don't have a problem. To me, that's like remarkable. Where if the only way you would know that you had a brain aneurysm was if you were suddenly had the worst headache of your life and died like within 24 hours, I mean, you haven't got a shot. Whereas if you're actually picking this up randomly, I mean, that's empowerment in my view.
Yeah, I mean, even before Prenuvo, like the only time I saw aneurysms was when somebody came into the ER with the worst headache of their life and there was already blood, it already ruptured and there's blood everywhere. And then incidentally somebody comes in, with headache or for some other workup, and you happen to catch an aneurysm, so
Yeah.
it wasn't,
It's just one of those things. And same thing goes for certain types of cancer. Like we talk about like pancreatic cancer. Pancreatic cancer, of course, is not something I dealt with as a surgeon, but I mean, we all know, and probably pretty much everyone listening to the show has heard a story about somebody totally healthy. They get the diagnosis of pancreatic cancer and they die within the next 3 months. And the issue there is that the only time that people really find pancreatic cancer is when it's way too late, right? And effectively, that's so. What percentage of people, John, are get cancer in their life?
I mean, it's like, what is it? We have a 50% chance of developing cancer throughout our life. And then there's all these other factors that play into that, exposure to different environmental factors, even stuff that we're eating. I mean, so there's so many different factors that are increasing our chance of developing cancer throughout our life.
Totally. And the bottom line is, if over half the people are going to get cancer at some point in their life, then this is giving us a chance to actually catch it. So let's talk about the technology a little bit. The technology is MRI. It's funny, we were talking offline. I'm a fan of Peter Attia, and I went back when we were going to do this interview to see if Peter had talked at all about this, and I listened to that show, and it was, as usual, Peter's so smart. He was too smart for me, and I just was like, it was like a show full of physics and stuff. For the rest of us, Sean, tell us a little bit what MRI is and how does that compare to a CT scan?
Yeah. So in simplest terms, think of it as patient goes into this magnet. A radio wave, which is non-ionizing radiation, is sent in, then it's turned off. Then the patient emits a signal back, which is received, and then that's used to create an image in the most simple terms.
Right.
Now,
right.
Yeah. Just say the big difference here between the other modalities that we commonly know of, X-rays and CTs, is that there's no ionizing radiation. So we could potentially do this every day, and we don't know any really harmful side effects.
Yeah. And in terms of image quality or the types of images you get, how is it different from some of the other modalities, whether that's CT, ultrasound, X-rays, just so anybody in general knows why a company would necessarily pick MRI outside of the fact that it's essentially not a radiation risk?
Yeah, the MRI really gives us great soft tissue contrast differentiation, and what I mean by that is the ability to kind of tell us the different properties of the tissues. So like we can differentiate fat, blood, simple fluid, muscle tissues. So it really helps. Whereas like in a CT scan, we're looking at radio densities and we're basically looking at like bone, soft tissue, air, fluid.
Got it. And then in terms of Prenuvo, what I thought was interesting and that I didn't know, and again, this goes back to, initially thinking, well, gosh, what's the big deal about whole body MRI and this company, is what you guys are doing is different, which I thought was fascinating. What you've done is you've taken, this is sort of an engineering marvel, right? So I remember when I was back in my surgical days, an MRI for the brain alone would, be over an hour. But now you've got this ability to do not only a whole body MRI, but to do it in a way that the image quality is really superior to, according to at least my radiology friends, than what you're getting at a lot of medical centers. How is that possible?
Yeah, and it's really important to be able to maintain that diagnostic imaging quality even in the screening setting, right? But the way that we can do it is like Prenuvo focuses on whole body MRI. That's what they do. That's what we do. And ultimately what they're doing is they're optimizing the hardware, the software, and optimizing the protocol. So when we're going through this exam, like you had said, a brain MRI, a full dedicated brain MRI can take 40 minutes, 45 minutes, even to an hour. we're taking the most high yield sequences, the images for each section of the body, to give the most clinically relevant information that's needed to say, hey, there's nothing here that we need to worry about, or hey, we need to monitor something, or we need to work something up.
There's a couple of terms, and again, don't want to get into the weeds too much because I think the physics on MRIs is very complicated. But there was a couple of terms that I thought were useful to define and to understand how they were being used in terms of this technique. And one is multiparametric imaging. What does that mean?
Yeah, so essentially, pretty much every MRI is multiparametric to some extent. And what it is that you're taking the sequences, we can say tissue weighting, not to get too technical, and you can either, let's say, suppress the fat or highlight the fluid. And that's where the multiparametric comes in, because you're using different sequences to tell you the different characteristics of the tissues and fluids.
So it's almost like you're going and you're using different, like on Instagram when you
filters.
Use different filters, right?
Yeah.
And so you're able to see things differently, and in one filter might pick up a tumor better, and in another might be better for picking up aneurysms, or it might be tissue specific, right? Like if you have brains might come up better in a certain filter, and guts might come out in another.
Yeah. I mean, you
right?
can take something simple as like a lipoma, right? A benign fatty mass that are really common in us. We can do a sequence where we look at it and it shows the fat is really bright, and then we take another set of images and we suppress that fat and it gets really dark, and that confirms to me, hey, this is fat.
Yeah, that's fascinating. The other term that I want to talk a little bit about, and of course this isn't invented by Preventive, but it's something that's been is used a lot, is diffusion. Talk about what diffusion is and what the importance of that in this type of screening situation is.
Yeah, so diffusion weighted imaging is part of the multiparametric technique. And what it is in kind of simple terms is, think about a bunch of molecules in a vessel, right? And they're moving around. And then all of a sudden, there's more and more and more of them, and it gets really, really crowded. They become restricted. And that basically translates into a specific appearance on our images, so that we can say, hey, this is showing restricted diffusion. It's hypercellular, hard tissue. So
in the old days, if we take medicine 1.0 or even 2.0, what brought us our attention to, say, a tumor would be the fact that there is something hard, right? Like, if somebody had a mass somewhere, and that effectively is like dense tissue, dense cells. So effectively what diffusion is doing, correct me if I'm wrong, is it's able to sort of visualize something that is hard, unusually hard, and effectively doing that where maybe you can't just feel something. Is that right?
Exactly, because we can't feel all the stuff deep into our abdomen, so it really highlights that. Now, one thing is important to understand, that not everything that shows up on those diffusion weighted imaging means it's bad. It doesn't always mean it's cancer. There are certain things that do show up there normally, like lymph nodes, for example. Right,
totally. So, one of the other things that I was curious about, first of all, a couple disclaimers. I don't have anything to gain from Preventive. I just had a fantastic experience, and I'm very optimistic about this. But I have a friend who works for the company, but he just kind of is excited about it too. But that leads me to the next question. I was really, I liked what I heard about what my friend said about the screening process for the radiologist, because you can imagine a company like this, you think, big screening company, whatever. And maybe they're sending these images out overseas, and who knows who's looking at them and all that kind of stuff. But my friend was telling me that he got kind of pretty drilled with some quizzes and all that kind of stuff. And he was like, man, I want to work for these guys, because obviously they care about the quality of the radiologist, and that's really important. And you talk a little bit about that?
Yeah. No, we 100% care about quality of our work and people's level of interest. And part of that screening process, those example exams or tests, per se, is to give the radiologist who's showing interest an opportunity to see the type of imaging that we're doing, and also get a level of understanding of, their level of understanding of MRI,
Yeah.
And it's not to exclude people. It's more just to get, better understanding of what's going on. And if, we need some more training, we're happy to teach, and particularly how to read whole body MRI, because it's not really taught in residency. So.
Is that right? Oh yeah. Well,
Yeah,
of course, right? Because nobody teaches whole body
parts. So,
yeah, of course. No, that makes sense. That totally makes sense. Okay. So, let's get sort of into the, first of all, let me just kind of tell about my experience, and then we can talk a little bit about what this thing does. So for me, it was really one of the easiest things I could have imagined. I literally popped in to the Los Angeles office. I was told not to eat or drink anything for 4 hours. Pretty easy for me because I'm doing intermittent fasting anyway. And I went in there. There was virtually no wait. I thought I was going to do one of those cool Instagram things where I was like sitting in the waiting room, like, I'm going to go get this. I'm a little bit nervous, all that kind of stuff. But there was no time for it at all.
That's awesome.
They loaded me up into the MRI machine, and I'm thinking, okay, here we go. This is going to be boring. The MRI, they put glasses on me and asked, what I wanted to watch on Netflix. And I'm 6'4", about 215 pounds. I didn't feel claustrophobic at all. Didn't feel squished. Didn't feel uncomfortable. And actually, for me, it was actually one of the more relaxing hours that I've had in a long time, because I was just sitting there watching Netflix.
Yeah, and I think that's like the game changer, right? Being able to
Right.
distract yourself, particularly people who are claustrophobic, or they don't even know they're claustrophobic at times, but when they get into a tube, it may trigger that claustrophobic experience. But I think it's a huge game changer.
I mean, yeah, and it was so quick. In fact, when it ended, I was in the middle of a show, and I was sort of like, can we just keep going for just a little bit longer? I want to see how this ends, but we couldn't, so we had to move on. Anyway, super easy, and we'll get into. I want to get into my results a little bit if we can in a bit, but let's talk about what we're screening for, because it's not just cancer. It's, obviously that's part of it, but we're talking about like 500 different conditions. What types of conditions are we talking about?
Yeah, I mean, it's several hundred conditions. We could be looking for anything from, tumors, right? Benign and malignant type tumors that could pose problems for people, brain aneurysms. And then like a big one that people don't think about is just underlying metabolic disease, right? So we're looking at visceral fat, subcutaneous fat, fatty liver disease, iron overload in the liver, even underlying cardiovascular disease, just by assessing, different types of signal changes in the brain.
Right. So I heard, now this is interesting, in your first group of people that went through this, you found something like meaningful kind of bad stuff, like tumors or aneurysms, 5% of the time. That actually sounds really big. Do you feel like that is that normal, or do you think that there was something about that group or that population that made them more likely to have something like that?
Yeah, I think it's a small sample size, so, and that it may have been, that something related to that particular group. We are actively working on doing more prospective type research and studies to get more quantified data so that we can present it and, show people the actual value here.
Yeah. And I guess that's, and I mean, not that it makes a difference. My guess is, in talking to my friend who's with the company, that he actually doesn't see anything anywhere near those kinds of numbers. And we were talking about why that might be. And is it, this is a totally elective type thing. And the people who are going to go do this probably are very healthy to begin with. Whereas if you're doing a study on a bunch of people, who are not paying for it, and also in a certain demographic or an area, you have a completely different population size, right? But anyway, I have to say, when I heard the 5% number, I was pretty freaked out about getting the study, because I'm like, oh great, like I need another problem. But that's part of the perspective, is like, a lot of people don't want to know, right? But the thing about, and let's talk a little bit about that, is because people out there are thinking, if I got a problem, maybe I don't want to know. Why is that not a good way to think about this?
Well, the way I think about it, and I totally understand that perspective, right?
Yeah.
Like, I don't want to know. I don't want to deal with it right now. But the problem is if it does manifest into something really bad, then you're going to have to deal with it. And the options are going to be way more limited. Treatment options are significantly narrowed at that point, particularly when disease has spread or something is like more complicated than it originally was if you catch it early.
And you're catching most stage 1 cancers, right? I mean,
I would say we're catching early disease. In terms of staging, the way I think about it is like, let's say I see a tumor confined into an organ and I don't see any other signs of disease spread. I'm thinking it's stage 1. Obviously, I can't see tiny little cells that have already gotten out. But yeah, I would say early stages for sure.
Yeah. And the reason I bring that up is, again, we're in a... we've been battling this whole battle with cancer for so long with technology, and it may turn out that way before we have the technology to sort of knock out all cancers in late stages, we may have all of the ability in the world to detect them when they are almost all uniformly treatable. And that's kind of what I think is really exciting about this. In medicine, we talk about sensitivity and specificity when we're dealing with various types of studies. I know, again, it's going to be hard to give these kinds of numbers. First of all, what is sensitivity and specificity? If you could just remind people, and then in terms of picking up big bad things, do you have any statistics on that?
I don't have any hard numbers to give right now, but if you think about it as the ideal screening test would be high sensitivity and specificity. So with MRI inherently too, with all the amount of detail that you get, it's a very sensitive test. I know
and sensitive means if it's there, you're going to pick it up.
Exactly. And then being specific, saying, hey, is this real disease or not? Is this something and then I'm kind of altering it a little bit, but being able to identify what it is, a cyst is a cyst. Hemangiomas in the liver are hemangiomas. So being able to really nail it down is key to this screening process.
Do you guys have an idea of kind of what you, how you envision this being used in terms of, I guess obviously it's a totally elective thing right now. And I don't know how far away insurance companies are from maybe accepting this as something as part of routine scanning or whatever, but maybe you can answer that question. I mean, are insurance companies even considering this, A, and B, if they are, how do you guys envision it being used ideally?
Yeah, I think at this point, the vast majority of insurance companies are not covering this. I have heard certain patients that have come in said that they were able to get it covered, at least parts of it. I don't know the time frame that insurance companies will actually start to cover it. Like any of these screening tests, it always takes them a while. But the way I envision this, and I think other people do too, is that, this is basically like a physical exam of the future. And it's not meant to replace the standard physical exam. It's meant to help, I almost think of myself as a primary care radiologist. I want to be at the forefront and help, with preventative medicine and help direct care to prevent things from, spiraling out of control.
Right. As it relates to cancer specifically, another thing that you and I were talking about offline is, I did an interview with the Grail company who does the Gallery test. The Gallery test is basically a blood test for cancer. Just another very, very exciting, way of potentially picking up cancers very, very early. And what initially I think somebody had thought about either or, and I look at these potentially as extremely synergistic, right? Like if you had both this kind of total body MRI with all these high quality images and a blood test, I mean, to me, that would be sort of the holy grail to make sure you're good to go. I mean, you'd sleep pretty well at night with that kind of data.
Yeah, no, I'm in 100% agreement there. I think that they are synergistic, and they're so much more powerful used together, right? Because we, by imaging, are looking for changes in what we see as normal, and we're looking for masses, right? But these tests are actually looking at like cells in the blood. So being able to combine that is really going to be a huge game changer going forward. And the important thing to note too is that, you know, these things are not meant, ideally they should be used at different periods of time throughout one's life, as opposed to just like, hey, one time we're cancer free. It doesn't really work like that.
Right.
So both the blood test and the imaging are most valuable with longitudinal assessment.
Do you have a sense at this point, like, I know I think about, like, again, comparing these types of techniques with, I mean, and you know mostly about the MRI. We don't need to talk about Grail anymore, or Gallery anymore. But when you compare the screening tests that we have, for example, you know, mammogram, is there any reason to believe that mammogram or colonoscopy necessarily would be more accurate or better screening tool than doing whole body MRI? I mean, what's the deal there?
I still advocate for those screening tests. I think they're incredibly valuable because there are always limitations to every screening test, right? So let's take breast, for example. We're not necessarily dedicated breast screening. We're not breast imaging, I should say. We do look at the breast tissue and we're looking for anything, but it's not tailored for the breast per se. Now, one thing I cannot see that mammograms are great at picking up are microcalcifications, which can be a sign of like stage 0 breast cancer, very early breast cancer. So I'm missing that on this test. So we still need mammograms. Colonoscopy, we don't prep patients necessarily to clear out their colon. We're not inflating anything. So polyps are very difficult for us to pick up. In fact, I'm probably not seeing a lot of polyps because there's stool content mixed in there. So I can't always see polyps. That's where colonoscopy is incredibly valuable. They go in, they see a polyp, they take it out. They can look at it under the microscope and say, hey, this is a benign, boring polyp, or hey, this is a precancerous polyp. Let's get you on a more frequent screening colonoscopy program.
When one other thing I thought was really, going back to talking about this as a medicine 3.0 approach, my friend who works for the company was saying that one of the things he thought was really interesting is that, you know, now when he gets these scans, he's looking at them with a completely different perspective that he ever looked at as he looks at in hospitals all the time. Because again, somebody isn't sending him something that says rule out, you know, brain tumor or rule out, you know, appendicitis, as you mentioned. It's, hey, take a look and see what you see and tell us if there's anything wrong. And because of that, he's noticing things that he probably wouldn't have really thought about before. And one of the things he mentioned I thought was really interesting was sometimes he'll notice that somebody's really thin, but they'll have a bunch of visceral fat. In other words, a bunch of fat around their organs. And, you know, it's sort of this skinny fat kind of, you know, terminology.
Exactly.
That's something that you wouldn't really comment on as a radiologist. You wouldn't say somebody's, you know, it seems like they have a lot of, you know, more fat around their organs than they should. But that's the kind of thing you're looking here, because that is a sign potentially of metabolic disease, right? Like of being unhealthy in other ways. You want to comment on that a little bit, on how that works for you?
Yeah, and I totally agree with his perspective. Like when I look at these exams, like, you know, the vast majority of people that come in are coming in for preventative reasons, not necessarily diagnostic. And so we're trying to provide valuable information that you know, we as humans can control. and because we can't control everything, we're given a blueprint. And if there's something that we can alter in our lifestyle to improve our daily life and longevity, we want to be able to provide that information, and also put it in a way that they can see change over time. If they do lifestyle modifications, we want to be able to present it so that they can see that change by imaging as well, and show that it's actually working.
What are some examples of that? Like so outside of tumors and stuff?
Most common thing in our culture, fatty liver disease, right? Yeah. And it's generally due to alcohol and terrible diet, lack of exercise. And, I've seen patients who come to us and they've had severe fatty liver disease. They make those lifestyle modifications. They exercise, they stop drinking, they change their diet. It reverses and it goes away. Yeah.
It's fascinating stuff. Like, it's like, the gamification of medicine, right? Like I have, I always talk about, I wear an Oura ring. Now I've got an Apple Watch on, and it's like, now it's a game. If your sleep is not good, you're trying to like reverse it. And if you can reverse it, then it really becomes like a game that's kind of incentivized to perform. So I think that's actually as nerve-wracking as it may sound to people, that actually is, to me, a great thing, because you actually have potential control to reverse some things. Yeah. So let's talk about, and we talked about who's getting these scans. Right now, it's not generally cheap. How much is a typical scan cost?
So our scans, we have 3 packages ranging from about $1,000 up to $2,500. The most comprehensive is $2,500. I think the middle one's around $1,800, and then the torso exam, we call it, is $1,000.
Got it. And okay, so I had a whole body MRI. Let's, if you don't mind, you have my results there?
Yeah, I can pull them up.
So, I haven't looked at these like in much detail, so this will be interesting to me too. We could just hit some of the highlights, and just let me have it. What's
hold on, let me see if I can get your results here so it's all fresh.
Yeah. It's a huge report, by the way. I got the report and I was like, okay, I'll just look at it real quick. It's not like your usual MRI report. This is a lot of information.
So I think, to begin with, I always start off, the way I think about these exams is like somebody comes in for preventative reasons, right? Like you, in your case, first thing I'm going to say is, is there anything that we need to worry about or not? And so in your case, no, I don't see any suspicious masses throughout your whole body. I didn't see any brain aneurysms. We see a couple tiny little white matter changes in the brain, which could even be, it's a kind of a broad differential. It could be something from like chronic migraines, old head trauma, little small vessel ischemic damage, whatever. But it's nothing that we have to act on right now.
Right. Hey, let me ask you about that. I mean, not to get too specific on it, but I had COVID pretty badly, and I had like brain fog for like 4 months. Is that something you might see in COVID?
It's totally possible, because with COVID, it sets off this like the massive inflammatory response, and we are, I think, becoming more aware how inflammation is quite damaging, particularly when it's like uncontrolled. So I think these little white spots in the brain, they're so common. We see them all the time. And it very well could be from events like that.
Subcortical white matter is where those are. You have a sense where, by the way, where are they?
They were in the frontal regions, and it's actually a really common spot to see them.
Okay.
You could have had these things forever, and based off their appearance, like, I'm not worried about them. Like, the brain looked great otherwise.
Yeah. Cool. All right. What else did we see that was interesting?
One other thing that I thought was interesting, and you may be able to add into this, is your thyroid gland had a bit of a prominent, kind of a swollen appearance. Now, I don't see any nodules are in there, but it does make me question, even if the thyroid blood tests are normal, like the function tests are normal, it's something that I would be curious to know if there's any autoimmune markers underlying there, even if you don't have symptoms. Like, could this be some transient process, or is there some like early autoimmune disease process that we don't know about? Yeah. But it's hard to say without having the other information.
Well, that's interesting. Actually, I did have normal thyroid tests recently, although my mother does have Hashimoto's thyroiditis, which is pretty common, the most common type of hypothyroid. So that's something that's good for me to know about to follow up on.
Yeah.
Here's a non-aggressive. Oh, okay. Talk about the next one.
Yeah. So these little pancreatic cysts, right?
Yeah.
And this is what I mean by MRI is so sensitive, right? So
Right.
we do specific images, and there's something called an MRCP, and it's really looking at the ducts coming out of the liver, gallbladder, and the duct in the pancreas. And sometimes we can see these little side branches coming off the main duct, and they, for whatever reason, they occur, but they're really low risk. All right, the chance of them becoming something bad is really, really low. But we've known from studies that, we observe them over a long period of time. Some of them can transform into something bad, so we just surveil them.
Yeah.
Really nothing else to do with it, though, because and particularly with this imaging, I mean, I see these things so frequently, and on follow-ups, they generally are all unchanged.
Yeah, next one on my spine, just as a little history there. I've had lumbar, so lower back surgery, three times, including a fusion, a discectomy, and also, so that stuff, there's a bunch of stuff there. But I was surprised that there's a bunch of stuff in my cervical spine there. You want to talk a little bit about what you're seeing and what might be worth, following up on? Because I'm totally I don't have any symptoms of cervical spine issues. So,
and that's, I was going to ask you that, because that's such an important piece of information, is we don't just treat images, right? We treat, we look at images and we treat people based on, is this actually causing you any problems at this time? And so the stuff that I was seeing in your spine was pretty typical in terms of chronic degenerative arthritis. There's disc bulging and some bony spurring, and it causes narrowing of the central canal or the spinal canal where the spinal cord lives. And the key there, what I'm always looking for, is there anything really squishing, compressing the spinal cord that could be problematic? So anytime I see that, I do make comment of that. And then I'm also looking for any kind of abnormal changes within the spinal cord due to that compression, because it can cause swelling and create symptoms from that as well.
Interesting. Well, net, I'm not unhappy with these results. I mean, it seems like, there isn't anything big or bad to worry about. So that sort of leads to the, frankly, the one additional benefit of doing this kind of study is peace of mind, right?
Yeah. And I think with even the spine stuff, for example, all of us have some degenerative process at some point of our life in our spine. We get arthritis. And being able to see it and know that it's there and where it's at that time, we can kind of alter some of the way we live our life. I'm a radiologist. I sit at the computer all day. When I get tired, I start to slouch, my posture. So it reminds me to be okay, take more frequent breaks, try to be more ergonomic, get a standing desk, things like that. It doesn't mean you have to go and, get more spine surgery, for sure. Want to do lifestyle modifications first.
Well, this has been a very, very interesting and useful experience, Sean. I want to thank you so much for being on the podcast. And how do people maybe just give people an idea of how to sign up for Prenuvo if they want, and look into what's the website? It's prenuvo.com.
Prenuvo.com. You can go onto the website, and people can sign up for the different types of exams that they want directly from the website, or they can call in into the to the office and ask more questions and sign up that way as well. So
fantastic. Well, I got to tell you, I had a really great experience, and it's not something I really had expected. I thought it was going to be in an MRI chamber for 8 hours, and on all this. And then I was worried I was going to have just for that moment right beforehand, because I hadn't really looked at this. I was like, oh, great, he's going to tell me something really bad. I'm going to be on this show. And then it'll go viral, though, because look at the expression in his face. And
Oh man, no, you're good, and I'm glad you had a great experience. That's great feedback to hear. So, and I really appreciate you having me on here. So,
yeah, thanks so much, Sean, Dr. Sean London with Prenuvo.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.